Good afternoon. I want to welcome everyone today to UCSF Family and Community Medicine Grand Rounds. Our speaker today is Dr. Jennifer Karlin, who will be speaking about expanding self-injectable contraceptives in the U.S. from a person-centered perspective. Just a few reminders before we get started. This session is recorded, and if you would like to go back and watch this session or other sessions, it will be uploaded on YouTube, and you can find us on the UCSF Family Medicine website under Grand Rounds. If you want to go back and watch other Grand Rounds, they're there as well. We're hoping that today's session will be an engaging and exciting one. It's a terrific topic. We would really encourage everybody to send us your questions or your comments by using the Q&A. You can just type into the box there. Also, if you have suggestions or feedback for today's speaker, for Jen, or for other ideas about other topics you'd like to see covered, please fill out the evaluation that we'll put into the webinar when we get going. As always, I want to say special thanks to our tech team, Benjamin Wallen, Erigo Mitchell, and of course to Roy Johnston, who is always wonderful to have here. Very much appreciated. And before we go on with Grand Rounds, I have to just make one plug for getting ready to prepare submissions for the UCSF Family and Community Medicine Rodnick Colloquium. As you know, it's just around the corner. It's coming up in May. That's pretty soon. So the submissions will be upcoming in the relatively near future. Hopefully folks are getting ready, thinking about what you'd like to submit. But as a special announcement, we also wanted to remind people that we have new updated anti-racism guidelines. So as you're putting your submission together, please take a look at those and contact us if you have any questions or there's something we can do to help. As I mentioned, today's speaker is Dr. Jennifer Karlin, and her talk, for those of you who just joined later, is expanding self-injectable contraceptives in the U.S. from a person-centered perspective. In today's presentation, Jen will focus on her research in expanding injectable contraceptives in the U.S. for self-injection. She will trace 3 steps of a research program thus far, starting with an implementation project at the Family Health Center at San Francisco General during the COVID pandemic, to qualitative interviews with patients in San Francisco and Washington State, to a nationwide survey and interviews of interprofessional healthcare providers about barriers and facilitators to expansion of the contraceptive use. Tracing these 3 arms of this research program so far and discussing next steps, Jen will use this example of expanding self-injectable contraceptives to illustrate how research can remain centered on equity, sustain a person-centered lens, and develop more formal research plans from an emergent need. I really think today's presentation is a special one because for me as a family physician, it really speaks to me about how we make an impact for our patients. Jen's work illustrates the transformative impact that family physicians can have in identifying barriers to care, collaborating with diverse populations, and translating advocacy into actionable change. Dr. Jen Karlin is a board-certified family physician who completed her residency at San Francisco General, and most importantly, was on the green team for linkage, and we were delighted to have her then, and we were delighted to have her back. After finishing residency, she subsequently completed a fellowship in family planning at UCSF, San Francisco General Hospital, and is now on faculty at UC Davis. Jen focuses on expanding and supporting reproductive and sexual health through primary care. Jen trained as an anthropologist and a historian of medicine. She has her PhD in these areas, and her research addresses how we can alter healthcare relationships and systems to encourage patient empowerment, autonomy, and equity. Additionally, Jen is committed to medical and resident education that encourages physicians in training to approach their practices from a historical, trauma-informed, and self-reflexive perspective to improve quality of care and decrease additional trauma caused by the medical system. So with no further ado, I am absolutely thrilled to welcome Dr. Jennifer Karlin. Thank you for joining us, Jen.
Thank you so much, Margot, for that introduction. I am so grateful for the opportunity to be able to speak today at my alma mater. And I wish I could see everybody in person. I really appreciate the invitation from the department and for Margot and the tech team for helping with all of this. So thank you very much. So Margot gave a very good background about me, but yes, I have an MD and PhD in anthropology and history of medicine, and my residency was in the department, and I continued to do my fellowship in the department. And the only disclosure I have is that I am consulting for Afaxis, which is a pharmaceutical nonprofit company. So to get started, the learning objectives for today are first to describe how expanding access to the option of self-administered injectable contraceptives in the US is a matter of both quality and equity of healthcare, to identify patient experiences and preferences for self-injectable contraceptives, and then to be able to describe some patient, provider, clinic, and system level barriers and facilitators to expansion of this for home use in the US. But I have another larger fourth objective, which is more in regards to the research trajectory and thinking about this. So throughout the talk, I'm going to continually refer and return to sort of this image and how I've been able to maintain my commitments to equity and quality of care throughout all the steps of the research process, and that it was really based in those commitments that led this project forward. And as family and community medicine doctors, Margot alluded to this, we're privileged to be embedded and aware of community needs. We're sometimes the first people on the ground seeing some of these needs emerge. And so by responding to those needs, we could really make a big difference through our advocacy and our clinical work and our research, and then merging all of those things into action. So I will keep coming back to this fourth objective throughout the talk also. So taking a step back, the background about injectable contraception in the US. So depomedroxyprogesterone acetate, which is often abbreviated DMPA, but often called either just Depo-Provera or Depo or the shot by some people, is a progestin-only injectable contraception. It works by preventing follicles from maturing and stopping ovulation, and it also thickens and decreases cervical mucus, and it thins the lining of the uterus. So the typical failure rate is about 4% if used every 3 months, which is one of our most effective modes of contraception, and it doesn't protect against STIs. But there are other benefits beyond pregnancy prevention, which include reduction of endometriosis pain, a lower risk of uterine cancer when used long-term, and other benefits. And it comes in 2 different formulations. So one is intramuscular, meaning that you inject it into the muscles, and the other one is subcutaneous, meaning injected into the fat. And they're often abbreviated as DMPA-IM or DMPA sub-Q. And I will probably use the abbreviations throughout the talk because it's a mouthful to say depomedroxyprogesterone acetate over and over and over again. So in the US, this is a little bit of a timeline, a history of Depo use in the US. So in 1959, it was first introduced for menstruation management, and then later approved for endometrial cancer treatment in 1969. Between the late 60s to late 70s, it was tested as a contraceptive on about 14,000 women in the US. And 50% of the research subjects were African-American, were low income and rural women. And most of them did not have clear consent for participation in the trial. So that's just some of the background of this particular contraceptive that we need to keep in mind as we're moving forward and talking about expansion of it. Then Depo-IM was approved as a contraceptive in the US by the FDA in 1992. And that was followed in 2004 by approval of the subcutaneous formulation, which was approved by the FDA for administration by a healthcare professional only. And that label still stands as of today. So just some clinical practicalities. Most of us are familiar who are clinicians with the intramuscular version. So again, one thing to point out is that between the intramuscular version and the subcutaneous version, there's different places to inject because of where our muscles and fat usually lie. And so there's a picture in the front, the first slide picture of where you would inject subcutaneously. And oftentimes intramuscularly, it would either be in the gluteus or in the deltoid. And then another another characteristic of the subcutaneous version is that it comes as a pre-filled syringe. It has about 30% less hormone and less volume than the IM injection, and it comes with a smaller needle. So all of those characteristics that I just mentioned, that it's pre-filled, that it has less hormone, less volume, and a smaller needle, lend itself to self-injection easily. And the third thing is that it has the same exact contraindications and side effects as the intramuscular formulation. So what that means is that, for example, we do not need to change the amount or the formulation for higher BMI, that there's very few actually level 4 contraindications of both the subcutaneous and the IM version. So it can be used in a large population. And then the other thing to point out, because people bring this up a lot of the time, is that there is a black box warning on both the IM and the subcutaneous version about bone mineral density loss. But that black box warning has actually been not found to have clinical relevance, and both ACOG and the CDC mentioned that it is not, it should not be a reason not to continue either formulation. And then lastly, the timing for the subcutaneous and the IM version are both the same. They're every 3 months. So those are the main things to think about when you're thinking about Depo. All right, so who uses Depo in the US, just generally? So I have a picture of the Pfizer packaging up at top, because it is going to be different than the version used internationally. But mainly in the US setting, it is Black women and teenage women who use Depo generally, whether it's the IM or subcutaneous version in the US. And then in comparison with the international settings, where we see the Cyanopress, which uses a Uniject model for injection, which is not available in the United States, you see how much different Depo use is in international settings. So on that first left side of the slide, you see that in the US, it's about 2% of the population using Depo in general, and it is much, much higher in other places internationally. And then if you look at that graph on the right, you'll also see that the percentage of subcutaneous formulation is much higher in other parts of the world than in the United States. And then lastly, I just wanted to summarize some of the clinical evidence about self-administration of the subcutaneous version. So we get a lot of this data from two main systematic studies, the two that are referenced on this slide, Kennedy and Burke et al. Systematic studies show us from data from mostly internationally, as I mentioned, but also in the US, that continuation of Depo subcutaneous version at 12 months actually has a higher continuation rate for self-administered versus provider administered. So we also saw, when it was broken down by younger or older women, that there was no difference for the self-administered group, but for the provider administered group, younger people had less likelihood of continuing if it was provider administered. In terms of unintended pregnancy, there's no differences in unintended pregnancy rates, and no difference between younger or older. And then in terms of side effects and adverse events, both were very low in both groups, and no difference in age group, and no difference in self-administered or provider groups. Although there is a note on the subcutaneous version that there can be dimpling at the site of injection, which is not noted in the IM version. And then lastly, we have studies about interest in the US. So a large study of about 1,592 individuals across the US showed that about 21% of people were interested in self-administering the subcutaneous version. And the people who are most interested were people who used some form of Depo in the past, but also were people who had trouble refilling their prescription, or had trouble just returning to clinic or having access to clinic in general. So that is the data that we had as background about subcutaneous depot for self-injection. And now I'm going to sort of start telling you the story about how the research has changed and what we know about self-injection now. So the first part of this is talking about moving from community needs to implementation. Okay, so to summarize, depot, the subcutaneous version for self-administration, has been taken up much more greatly in the international setting and not in the US. Most of the people who use depot in the US are disproportionately non-white, they're adolescents, or of lower income. So for example, while about 4.9% of all US contraceptive users use depot, 12% of those who are Black use depot. And so the restriction of access of subcutaneous depot for self-administration may stem from and also contribute to these systematic racial health disparities that we see. And if we think about it, if Black patients are disproportionately then bearing the burdens when we create a method that can safely and effectively be used in the home setting, and we're not making that available. So this is very inconsistent with equitable healthcare delivery. And then also there is a long history of forced sterilization and targeted marketing of depot. I alluded to that earlier in the timeline of depot in the US. At the same time that is the truth of our history, the literature also supports that Blacks and Latina patients prefer methods that allow for more patient control, including the ability to choose when and where they want to use them. And so with the knowledge of all this and sort of my commitments previously, there became a need during COVID-19 for social distancing. And so what I want to point out that it was my background in family planning, my commitments that I already had, the skills that I had at being a family physician that kept all of this information aware and let me seize upon the chance of an opening when there were emergent needs in COVID-19 for social distancing. And so it was that allowed me to really push forward an implementation project. And so with recognizing that maybe we would be able to forward this with those needs, I called the Medi-Cal multiple times throughout the beginning of the pandemic to ask them if they would possibly pay for the subcutaneous version for self-administration during the pandemic. And I must have called and emailed at least 10 times and finally got in touch with Mike Wofford, who was the chief of the Medical Pharmacy Policy Division, who also agreed that Medi-Cal's goals of continuing contraceptive access during the COVID-19 pandemic aligned with expansion of subcutaneous depot for self-administration. And so he asked me to write a literature review. So I was able to put that together very quickly, given the data that I have just shared with you about the systematic reviews that had been published. And I sent that to them. And in April 8th of 2020, Medi-Cal temporarily agreed to pay for self-injection of depot sub-Q, and then they made it permanent subsequently. So now this is permanently covered both by Medi-Cal and by Family Pack in the state of California. And I actually joke, and this is something I want to point out, that I've spent 18 years after college training to be a researcher and a clinician, but it was just me being persistent and annoying and continually emailing and calling that really ended up making this difference. And so I really want to point that out for everybody in the audience who are family doctors and doing this kind of work with these commitments, because we all can really make these big changes if we notice these barriers and just try to address them. All right. So at the Family Health Center, we started this implementation project. And I'm going to just sort of work around the implementation really quickly. I discussed the advocacy that was needed for insurance coverage. But the other thing that was very, very important about starting this implementation research project was buy-in from everybody at the Family Health Center. So from leadership to our MAs, to our pharmacists, to residents, to our advanced care practitioners. We had to get buy-in from everyone. And what I will say, just as a short note, is that, for example, prior to the pandemic and expansion of this, it was our nursing staff that really managed all of the IM injections. And so it was a big change to start thinking about how can we educate about doing the subcutaneous self-injections when it was the nursing staff who were handling most of the people who were coming in repeatedly getting their IM injections. And so the nursing staff and the pharmacists were incredible to work together to be able to roll this out. And so we had to really change our clinic operations with everyone's buy-in. Then we had to think about how are we going to outreach to patients, right? Like a lot of people during the COVID pandemic were not coming into the Family Health Center. And so we had to think about how are we actually going to reach out to the people who are on IM depot and tell them about this new option of the subcutaneous depot for self-injection. And then there was the issue of working with community pharmacies. Now, I'll tell you that all I did was call the pharmacy and ask them when they could get the subcutaneous version. And they told me, oh, we would have it in 3 days. And I'm highlighting this because this comes up as a main barrier later in some of the research that I do. But we had to work collaboratively with our community pharmacies. And I partnered with Sally Raffi, who is a pharmacist down at the University of California at San Diego, to really work hand in hand with a lot of our community pharmacies to educate them that this was an option. Because again, remember I said that the label is for a health professional only. And so sometimes people would go to the pharmacy and they would go to pick it up and the pharmacist would say, you need to go back to the clinic to get this administered. And that would very much, worry our patients who we had already told could self-inject and that this might happen. And then finally, we had to disseminate that information. So what we decided to do was use Epic as a way to look up all of the patients who had used Depot IM within the last year. So there were 90 eligible patients at the Family Health Center who were between the ages of 17 and 54 and who were non-pregnant and currently using or had used the IM version of Depot in the previous year. So we reached out to all of those 90 patients between May and August of 2020. And of those, 80% responded. And then of those, 63 were not interested because they either said that they were scared of injecting themselves, they wanted to stop Depot entirely, or they were satisfied with the IM version. And then 37% were interested. So of those 30% that were interested, we were able to get them appointments by phone or in person, if that's what they preferred, with either a pharmacist or with one of our providers, our healthcare providers, to teach about self-injection. And so of those, of the total number, about 21% successfully injected. And the reasons in between that discrepancy between the people who wanted to inject and the people who were able to inject was really logistical. It was because, they showed up to the Family Health Center for another reason, and it was noticed that their depot was late, so they just got the IM injection, or because they were having trouble with prior approval, or they were having trouble getting it at the pharmacy. So it was a lot of logistical reasons between that 21% and that successfully injected and the 37% who were interested. But what was even cooler and really drove me forward was also some of the comments that we heard at the beginning. People would say, I never thought I could give myself an injection, but this pandemic has made me rethink that I can do anything. And I'm so relieved that you reached out to me. I was just about to cancel my appointment. I was so nervous about bringing my 2 kids to the hospital just so that I could get my depot injection. And that one makes me really sad to think about it, because clearly they're much more worried about their children contracting a virus than about their own contraceptive needs. But it was really wonderful to see this. And after and during our implementation project, there were many, many other implementation projects going on. So for example, in Louisiana, there was a huge expansion of subcutaneous depot for self-injection. And then there were a bunch of other feasibility studies that also came out in adolescent clinics in Indiana and many places across the country, including Washington and New York State. And so with all of that information and with other forms of dissemination, not just the articles that I mentioned, but also toolkits. So for example, we disseminated this education and this new information through this toolkit online, which you can all access online and has been updated. But there are many, many other dissemination tools that a bunch of us and across the country were sending out so that providers could learn about this option. And so with both of those things at hand, with this extra data about feasibility of implementation, and with all the education we were doing, in 2021, the CDC updated their recommendations to say that self-administered subcutaneous depot is a user-controlled method that has the potential to improve contraceptive access and increase reproductive autonomy, and thus it should be available, and that it should be offered in a non-coercive manner through shared decision-making with a focus on patient preferences and equitable access to the full range of contraceptive methods. So what I want to point out again is that those values that I had at the beginning of person-centeredness and equity, with the merging of the emergent needs of COVID-19, led to the implementation projects and dissemination of this information, which then led to changes in expert opinions and CDC recommendations. So with that, now there's an opportunity to expand its use even further. But before we move forward, we want to make sure that we're checking in about if we're still focusing in a person-centered way. And so for me, that meant really understanding what are patients' experiences and preferences. Like, what were the experiences of patients who opted to switch to self-injection of subcutaneous depot during COVID that had been using the IM version? There were tons of questions that I wanted to know, even from the most basic, like, what do they call this? Do they call it depot? As I said at the beginning, do they call it the shot? What are people who are using this method of contraception calling their own method? And so we actually, that amongst a bunch of other questions we asked in interviews with patients who had switched from IM to subcutaneous self-injection, both in Washington State and in San Francisco. And here's some other questions that we had. How did they experience the counseling? Did this option change their feelings about contraception in general? What were the benefits and the downsides of self-administration? Did they feel differently giving themselves the injection than receiving it? How do they suggest, or do they suggest, that other people become aware of this? And how do we counsel about this in a non-coercive manner? All of us had done our best during the feasibility studies to build narratives about how to approach patients about this option, but we really wanted to know, like, did the way that we approached them feel non-coercive? Could we done better? So those were the questions that we went into this project with. And like I said, we recruited from the University of Washington and from UCSF, and we had a recruitment of a total of 15 patients. Here are some of the demographics of the patients, but you will see that most of them really do match up with some of that early data. that I mentioned to you all about who's using Depo. So younger ages, Black, African-American, Latin, and then less educated. And then we had a few other demographic questions about if they had children, if they were using it for contraception or for other purposes, and then how long they had used IM Depo prior to the switch. And this is some of the results that we got. So most of the participants, 93%, described subcutaneous Depo for self-administration as very easy or somewhat easy. And they mentioned that their primary benefits were convenience. So being able to give it at home, not having to go back for multiple appointments that were difficult. And they also mentioned, and I will give you some quotes about this one in a second, but they also mentioned a sense of privacy. This idea that they didn't have to go into the clinic and shout out that they were receiving an injection, and they could just do it in the privacy and comfortability of their own home. And then, of course, avoiding the logistical and financial challenges to in-person visits. And then we also said that there was a sense of increased self-capacity and autonomy over duration of use. And I'll give you some quotes about that in a moment also. Again, 93% would recommend it to a friend. The main logistical barriers that were identified by people who switched were the original barriers of obtaining the subcutaneous version from the pharmacy at the beginning, and then challenges with safe needle disposal. So something that we have to work on. And then they also made recommendations for increasing awareness of this option. And they said that all patients should be counseled about this, and that typical users should not be stereotyped because they thought there probably isn't a typical user. And then they highlighted these patient-centered benefits and outcomes. So here's just some quotes about interest and candidacy. I'm just going to read one of them, the middle one at this point. And the person said, "I just feel like it should be an option permanently. Just because there's a lot of moms and just women who have really busy lifestyles, and it's really hard to make appointments sometimes, especially when you're on a certain schedule. You have to get in when you have to, or otherwise you miss it and you got to start all over. It just makes it a lot easier. I feel like a lot of women would really appreciate doing it themselves." So that was somebody who had some college from Washington State, was about 30 and mixed race. I'll read you a quote about experience. I'll read you the top quote for this one. From a 53-year-old Black patient from San Francisco with some high school education. "I was actually very proud of myself because I've always had such a great fear of needles. I really thought I wasn't going to be able to do it. But the needle was only like half an inch. It wasn't that big at all. And when I did it, I felt accomplished, actually. I actually did it myself. So it felt great." And now I'm going to just show you some of these quotes about patient-centered benefits that we had not seen, we had not hypothesized beforehand. So about the privacy, I'll read the one about that. "I don't have to go in and do you need to bare your tush, and we're going to give you a shot here. And when was the last time you had sex? Or are you sure you're not pregnant? Or I don't have to tell anyone about that. I don't have to tell them, hey, I'm 42 and I'm not having sex. I'm a happy, crazy old cat lady. But it's just nicer to get it. Didn't even get questioned at the pharmacy. They fill it and, hey, you're ready to go. Cool." So that's a 42-year-old Caucasian from Washington State with some college. And then increased capability is also a nice quote. So this quote is, "I'm more satisfied at home because it's kind of like you're taking your own. It's like you just know how to take care of yourself better, you know? You're like, oh, I got this." It's not like you don't feel like, oh, I have to have somebody else do it for me. It's like, I can do it myself. And then finally, this idea of feeling trusted and empowered by the healthcare system was also really interesting to us. So I'll read that one also. "So just knowing that I can handle it and I can do it, and I don't have to go to the doctor to get it, and that it's feasible now. More feasible now to take control of your health outside the doctor's office. You don't have to go to the doctor for this or have to go to the doctor for that. They're opening up the channels of people being able to take a little bit more control of their health. It's like, okay, I got this. They trust me enough that I can do this, and that feels good." So in the end, when we're going to be publishing this, these were some of the patient-centered recommendations. So routine inclusion of subcutaneous depot for self-administration in all contraceptive counseling. Their second recommendation was provision of a sharps container when dispensing the subcutaneous depot. Third recommendation is tailoring educational format for patient preference. And to offer clinician observation of the first self-injection if wanted. So what they're talking about there is tailoring the education to either be in person or over the phone or via video or however is best for the patient. And then they really recommended discussing these patient-centered benefits like privacy. They said that they wish they would have known that there was improved ease over time and then the convenience during options counseling. They also recommended discussing directly with patients to remind themselves and how to do the reminders, and then to streamline pharmacy orders and insurance coverage and reimbursement to improve access. Okay, so that's the information that we got directly from the people who had switched over. And so now I'm going to talk about how do we move from this person-centered formative research to more systems level analyses. Okay, so this is where we're at now in this timeline. So now we have the person-centered formative perspectives, and now we're going to go to system level analyses. So we brought a really big team together. I've already mentioned the importance of working with many, many interdisciplinary team members for all of these projects. But we brought an even bigger team together to try to do a national survey of barriers and facilitators to expansion to at-home use of subcutaneous depot for self-administration in the US among experts in sexual and reproductive health. So what we did is a mixed method study. It was a convenient sample of contraception providers. So this included advanced care providers, nurses, pharmacists, MDs, and DOs. We did targeted sampling for geographic diversity, and then we excluded people with less than 3 contraceptive visits per month to make sure that they were people who were actively prescribing contraceptives in their work. So we did a survey and got 422 full responses. We asked people if they would opt into a second survey and interview, and 70% of them did. We also wanted to test the toolkit that I mentioned earlier. So this was a great opportunity to see if our toolkit was actually doing the type of provider education we were hoping it would. So we excluded people who had previously seen the toolkit because we hoped to expose them to the toolkit and then see if any of their knowledge or readiness for implementation had changed after the toolkit. Then we invited participants based on varying characteristics to interview and do a second survey. The participants then reviewed the toolkit, completed the second survey. So there were 33 of those, and we did a 1-hour interview with all 33. And this is how we analyzed the data. So from the first survey, we analyzed the data for some primary outcomes, which included awareness of this option, provision of the option, perception of suitability for patients, and readiness to prescribe. We then compared, like I said, the first survey and the second survey about readiness to prescribe and knowledge-based questions after viewing the toolkit. And then we did some qualitative data analysis, completing a 1-hour interview about knowledge, awareness, experiences, and perception of contraception. Here's where all of our providers were located. So very much heavily weighted in the places where abortion providers and providers of complex contraception are located. So California, Washington, New York, but then geographically dispersed throughout the US. And the only state that we did not receive a response from was South Dakota. Here are some of the provider demographics. So you'll see people are working in various different kinds of settings. We really wanted to look at Title X funding if the clinic was receiving it. We looked at the setting and then other aspects of demographics of the providers, like what their degrees were in and their age and how they identified in terms of race, ethnicity, and gender. And then we had some hypotheses about where these barriers and facilitators would come from. And so this is based on some work done by Dellendorf et al., actually also in your department at UCSF. And so we hypothesized that there'd be patient preferences and behaviors, provider-related factors, and then health system care factors that would cause barriers and facilitators to emerge. Again, like I mentioned, we had some primary outcomes: awareness, provision, suitability, and readiness to prescribe. And here were some of our findings, and I'm just going to briefly go over some of the larger findings and bring all of this information together for you all. So in terms of awareness, we actually had a really high number of people who were aware. So 78% were aware in this convenience survey of subcutaneous depot for at-home administration. And yet less than half, 43% of those who are aware were actually providing it. And so the reason why there probably were a large number of people was, again, that this was a convenience sample of experts from across the country who are in the family planning and sexual and reproductive health field. In terms of suitability, about 85% thought it was a suitable and promising option. However, there was a really large perception that interest among patients would be incredibly low, and that would make it not tenable. So it was thought that there would only be about 17% of people of reproductive age who might be interested in the subcutaneous version of DMPA-IM users. And then lastly, readiness for prescribing increases with access to workflows and toolkits that include information not just about the knowledge of how to do this, but about navigating the barriers like insurance and pharmacy distribution. So these were some of the factors for awareness that were significant. So completing a 2-year family planning fellowship, seeing a higher number of patients who have the ability to become pregnant, being an OB-GYN, receiving Title X funding, the DMPA sub-Q version being covered by Medicaid or insurance in the community, working in an urban setting rather than a rural setting or by telemedicine, and then working in a setting that also offered a high variety of contraceptive options, and then workflows being available or in place. And then there were factors that were significant for a lack of awareness, and those included being an internal medicine specialty, working at a Planned Parenthood, a pharmacy, or a freestanding reproductive health clinic. And so most of these overlapped with factors that were significant for provision. And I have put those with asterisks here. And then there were 2 significant factors for providing if you were aware. And the only significant factors were actually gender and the location where you lived. And if you were of male gender, if you identified as male gender or transgender, you are actually more likely to prescribe subcutaneous depot for self-injection than if you identified as a female gender, once you were aware of this option. And then also people who were working in a location that was considered a restrictive abortion state were more likely to prescribe subcutaneous depot for self-administration than people working in a protective or a moderately protective state, recognized by the Guttmacher Foundation for being supportive of abortion access. When people learned about it. So this was also really, really interesting. So as you can see from this pie graph, almost everyone learned about it during the COVID-19 pandemic. Or afterwards. So even though subcutaneous sub-Q depot for self-administration had been available since 2004, most people learned about it during the pandemic. In terms of provider practices, we also asked this of all the providers who were providing and prescribing sub-Q depot for self-administration. So 40% of those who prescribe talk about it to everyone. So not just people who are interested in IM depot. And then 62% allow their patients to report their pregnancy test. 12% said that the clinic required them to review the results from the clinic. And then 17%, a good 20%, said they just wanted to see the results themselves. 81%, so most people were providing telehealth support for at-home use of subQ depot. 69% did not send follow-up reminders for those who self-administer, and then 61% did use a mail order pharmacy. And then the biggest barriers and facilitators to prescribing. So remember, patients said that the biggest barriers were obtaining it from the pharmacy, the at-home disposal, and then getting insurance to pay for it. So the biggest barriers in terms of providers, and this is among all participants, is that patients are not interested and there's a low demand. They're unaware of how to order it or prescribe it. It's not in their EHR, their electronic health record, and they lack provider education material. So among prescribers, again, prescribers alone as a subset say patients are not interested, there's a low demand. There's lack of patient support for reminders and ability to follow up. And then there's financial barriers. The facilitators, as you can imagine, are the other side of this, which is that insurance pays for it. The resources for patients are easily accessible, and that patients are aware of it and ask for that option. So now I'm just going to give you some quotes from some of the providers. So I'm really naming this perceived patient level barriers. And the reason why I say this is because when we put this information in conversation with what we know from what patients say, we really realize that there's all of these sort of perceived patient behaviors that aren't actually what patients say their behaviors are. So for example, one of the providers said that, one of the themes that we found was that patients may forget to inject their DMPA subQ. Then the provider said, I'm really just puzzled about how we would be able to get people to remember to do this every 3 months. So, people remember to do things every 3 months that are important to them. And we did notice that reminders would be good, but all of the patients in our subset remembered to give themselves the subQ depot every 3 months. Again, patients may forget how to inject it. So the quote, an example quote about this is, my confidence is fairly low that people will remember how to administer in 3 months. Let's see. Again, patients having a fear of needles, of self-injecting. So a quote for that. The patient's biggest barriers, I think, is needle phobia might be one of them, or people are just afraid of needles. They don't trust needles. But you remember from our patients who switched to the subcutaneous self-injection, that they said even when they were afraid at the beginning, that they grew to not feel afraid after a while. And of course, that's a subset of people, but you notice the big differences in kinds of quotes about the barriers. In terms of provider level barriers, providers lack awareness. Providers have ideas about who makes an ideal or unideal candidate. And then provider bias against depot. And then again, the time to teach proper and safe injection, and providers requiring a pregnancy test prior to initiation. And this last quote, I prefer formal pregnancy testing. I just don't trust anyone. A really interesting thing to say about our patients. And then lastly, there were systems level barriers that were the same system levels barriers that had been identified by our patients. And one of the ones that I really like pointing out again is this pharmacy stock issue, because I think it really, again, points to our advocacy. These are people who've gone through a lot of education and are experts in the field, and they say, I don't know how our affiliated pharmacy is going to keep it in stock, or it's not always available in all pharmacies. But if you call a pharmacy will just tell you that they can get it in 3 days. And so it's really curious about where we get these ideas of where barriers come from and not. So I'm going to conclude here with some conclusions from this one study, and then conclusions about all of the studies put together. So again, given this is a convenience sample, it's likely that awareness in the general population of healthcare providers is just extremely much lower. And we do know that from other studies. But despite that, there's a big discrepancy, even among sexual and reproductive health experts, between awareness and provision. And so there's a big gap there that we really need to focus on. And the biggest barriers for providers are really these stereotypes about patient interest and contraceptive behaviors, most of which are not borne out in the general literature. And then the other biggest barrier is insurance coverage. And then the bigger other lesson is that provision increases with clinic workflow and toolkits that help navigate both clinical knowledge, but really the systems level navigation, including these perceived insurance and pharmacy barriers. So lastly, how do we move from these system levels analyses to interventions and outcomes data? And so, in conclusion, even though the subcutaneous version has now been available for about 20 years in the United States, and the evidence base for its effectiveness of self-administration has now been established, it's still just not often prescribed in the US. And I'll tell you that even, some of my colleagues don't, offer this as an option, even though I personally have discussed this with them. And so there is a big barrier about remembering to offer this during our contraceptive counseling. Most of the experts in the field learned about it during the COVID-19 pandemic. So that's very recent learning about it, when social distancing made it clear for its use, even though there were always these patient-centered and person-centered benefits that were in place. So if we keep an eye on equity and community minds and need and community needs in mind, we can really move forward our research agendas that keep in mind both our values around equity and person-centeredness, and then the voices and perspectives of the people who are affected by our contraceptive counseling and use going forward. And so the next steps would be doing more facilitators and intervention design. So that might look like studying, for example, decision-making and understanding patients' choices when provided different sets of options. So it may mean that, people don't want to put up with irregular bleeding if they're getting a injection and have to deal with the barriers of getting to clinic, but they may put up with that if they can give themselves an injection at home. Or it may mean that we need to develop interventions for forwarding, say, videos or reminders to patients, and doing teach-ins at different clinics and seeing if we can scale that up to a national level. Seeing what satisfaction looks like. So again, in the department, Dellendorf et al. Have developed a person-centered contraceptive counseling metric. And we could look at, does telling our patients about the option for self-administration actually change their satisfaction of the visit and the contraceptive counseling, despite if they use the method or not? So what are the effects of that trust that our patients told us about, that they feel when we tell them that we feel that they can do this themselves? So no matter what the next steps are, though, the most important thing is always checking back and making sure that we're staying true to our values and the commitments and being equity focused, especially when we're talking about issues of reproductive and sexual health, and always remembering to check back with the people who are being most affected from the outcomes of our research processes. So thank you very much. Here's some references.
On mute. Oh no. Jen, I want to thank you for an absolutely amazing and inspirational presentation. You've given us so much to think about as we strive for equity and really work to translate advocacy into action for our patients. We know we have a couple minutes, but just a few minutes. We have a couple quick questions that I'm hoping you can answer. The first one is from Connie, who asked, due to being 30% less hormone, what evidence, if any, is there of reduced side effects?
Now I need to unmute myself. Thank you, Connie, for that question. Yeah, there have actually been some studies that have shown some reduced side effects. But again, those have been in the international setting with the Ciana Press and the Uniject. And so we just need larger studies because we have not enough power right now with the number of people who are using self-administered subcutaneous depot. But yes, some of the early data has shown that there's less side effects with 30% less hormone. Good question.
That's a great question. And the other question is from Clarissa, who wrote, this is fantastic work. Is there any data on STI incidence and screening or testing with self-administration versus done in the physician's office? And then sort of subsequently, how do we get self-testing for STI and self-collected cervical cancer screening as well?
Yeah, that's a good question. Thank you, Clarissa. So there isn't actually data on if this changes the incidence of screening or testing in the physician's office. I will tell you that that was one of the barriers that a bunch of physicians and our healthcare providers have brought up. And one thing that I would bring up to think about that is that we really shouldn't be holding our patients hostage. If they want contraception, it's not necessarily linked to STI prevention. And as you mentioned in your second part of the question, it is true that there are self-collected, there's abilities to do self-collected cervical cancer and STI screening. So that is exactly where I would say if people want to be doing self-collected swabs at home for their STI testing and be giving themselves injections, that makes a lot of sense to put together if that's something that they prefer. But again, remember that we now have over-the-counter birth control pills and other things where we're not worried about people's STIs, and we're hoping that they will get tested for those things when they are able and ready to, and for public health needs. And so that would be some of the things to think about in terms of those questions. But thank you.
Jen, I want to thank you for a truly inspirational grand rounds today. You've given us so much to think about, so much to hope for in terms of advocacy, and a really, I think, a really generative discussion about how we think of our roles as healthcare providers or family or just family and person-centered care advocates. So thank you for joining us, Jen, and really appreciate your time. We'll let you end us with one final thought before we close.
Oh, I guess my final thought would be really, first of all, please tell your patients about this option. You might be surprised about, who will take, who wants to give themselves self-injection. So please don't stereotype your patients in terms of who's going to be interested or not. Just offer it like you would to all the options to everyone. And that's for providers. But for really everyone, I think what I've learned from this is, just the opportunities that really become available if you keep your commitments close to your heart and in your mind. When things become available, just call, just ask, write lit reviews. Don't take, your first no. And if you have a question like, is this offered in the pharmacy? Just call the pharmacy and ask. People will give you the answers, and then you might find yourself in a research trajectory that will help bring, more options to our patients in person-centered ways. So that would be my last ask of everybody who's been attending this webinar. Wonderful. Jen, thank you so much. And Kevin Grumbach, who never misses a beat, noticed that in the evaluation form, it is mislabeled as a different presentation for today because we had to switch speakers, but this is Jen's presentation. So please send us your comments and we will make sure that they go directly to Jen. Thank you for joining us today. Great to see everybody here. Have a great afternoon and wonderful weekend.